Good evening, all. Thank you, Dr. Satish sir, for the kind words. At the outset, I would like to thank Dr. Georgie Kenan sir and the ECNG platform to give me this opportunity today. The topic is from the second part, secondary hypertensive series. We are going to deal with pheochromocytoma today. So the outline will be about a little bit about secondary hypertension. What is pheochromocytoma and what is the paraganglioma? What are the pathophysiology, clinical presentations, investigations, and management of the same? Some nephrologist perspective, a case discussion, and some key take-home messages. So to start off, the secondary hypertension overview, when you look at it, we are aware that 10% of all hypertension is secondary, yet it is very frequently missed. And to suspect secondary hypertension, we look at very young age patients, less than 30, resistant hypertension, episodic symptoms, patient with unprovoked hypokalemia, with causes commonly between renal parenchymal disease and RAS, which we dealt in the last session. Endocrine causes like primary aldosteronism, pheochromocytoma, which we are going to deal today, Cushing's. Other than that, we have obstructive sleep apnea, drug-induced coarctation of aorta, and some of the monogenic syndromes like Liddle's, Gordon's syndromes. So with this overview, we'll take up the first poll of the day. Poll 1, 25-year-old male presented with episodic headache, sweating, palpitations. His blood pressure was 180 by 106 millimeters of mercury. He has no renal dysfunction, no renal artery stenosis on Doppler. His potassium levels are normal, and he has no history of consuming alternative medications and mood elevating drugs. What is the most likely diagnosis? 1. Pheochromocytoma, Conn syndrome, brainstem stroke with sympathetic overactivity, and Cushing syndrome. Please launch the poll. Over to you, Satish sir.
Yeah, so everyone start answering the poll. We'll give 10 seconds. So I think that's enough. We can now end the poll and then announce the results. Yes, I think most of the people have spotted the right answer in this thing and not been fooled by some of the other more likely answers. So the thing is, it is a pheochromocytoma, probably the diagnosis of choice on this. Conn syndrome, obviously, the potassium will be low. That's what we are expecting. Brainstem stroke with sympathetic overactivity, you would expect a more obtunded patient or a comatose patient. And Cushing syndrome, obviously, again, here, the potassium might be low and there may be other features like edema and all those things. So most likely pheochromocytoma. And with that, we go back to Dr. Vilesh for the discussion.
We heard the terminology as, so what is it about? Pheochromocytoma is a catecholamine secreting neuroendocrine tumor arising from chromaffin cells of the adrenal medulla. And as Georgie Kenan sir told us, that because of the dark staining of the tumor with chromium salts, that is the name as pheo, that is dusky, chroma, that is color, and chitos of the cell. So that is how the term was derived. And what is pheochromocytoma? Is basically arising from the chromaffin cells of the adrenal medulla. And when it arises from the extraadrenal sympathetic or parasympathetic ganglia, it is called as paraganglioma. And as an umbrella term involving both pheochromocytoma as well as paraganglioma, we call it as PPGL. So henceforth down the line in the meeting, we would be shortlisting it as PPGL. So looking at the epidemiology, almost 0.1 to 0.6% of hypertensive patients have PPGL. 2 to 8 million per incidence annually, and around the peak age of presentation between 35 to 45 years. Most important point is about the 40% hereditary germline mutation. The distribution is like adrenal 80%, extra-adrenal 20%. Most of them are functional. Some can be non-functional when it is present in the areas like head and neck. The rule of 10, which was once upon a time a great MCQ question, which 10% bilateral, 10% extra-adrenal, 10% malignant, 10% familial. These rates are now different for the current setup, but still the rule of 10 holds on. Malignancy mainly defined by metastasis and not histology. And the most malignant mutation is the SDHB mutation. So whenever you get a metastatic disease, you should always send for genetic study. And if it is SDHB mutations, we have to have treatment according to it. And most commonly in our setup, in the last so many years of my practice, what I found is that while doing an ultrasound, accidentally you find an adrenal incidentaloma. And that is what then, after evaluation, end up with one of the PPGLs. So what is the pathophysiology behind it? The chromaffin cells synthesize, store, and release catecholamines. And basically, it affects the alpha-1 adrenoreceptors, causing vasoconstriction, increase in the SVR, the hypertension, sweating, and pupillary dilatation. The beta-1 agonist activity increases the heart rate, increases the contractility, and may have arrhythmias. And most commonly on echo, we may find something like a cardiomyopathy, stress cardiomyopathy. For beta-2 adrenoreceptor vasodilatation, hypokalemia, occasionally hyperglycemia, mainly the sugar level, secondary to the metabolic effect of glycogenolysis. Associated also are lipolysis and some weight loss. So, what is and how is the clinical suspicion in a case of secondary hypertension that we think about pheochromocystoma? So, if you have hyperadrenergic spells like self-limited spells of non-exertional palpitation, some sweating, diaphoresis, headache, tremor, or pallor, patient is a case of resistant hypertension. They have a familial syndrome associated with mainly the MEN syndrome, the von Hippel-Lindau syndrome, and the neurofibromatosis 1. Any family history of pheochromocytoma, a presence of an incidentally discovered adrenal mass on ultrasound, presence of hypertension and diabetes, pressure response during anesthesia, surgery, or angiogram. Patient is a young hypertensive or presenting with an idiopathic dilated cardiomyopathy, a history of gastrointestinal stromal tumor with pulmonary chondromas, which is a triad of Carney's triad. So any of these can be one of the suspicion clinically to look for pheochromocytoma. So when you look at the clinical features, we know that the common triad, which was even the present in the question itself, patient having episodic headache, sweating, and palpitation. But this triad is only present in less than 50% of the cases. And the hypertensive patterns can be variable. You can have sustained paroxysmal. Some people may have a sudden hypertensive emergency or urgency. People even may present with a marked beta 2 effect presenting as an orthostatic hypotension also. But there have been cases where you have silent tumors where you will have 5% of the people presenting as normotensives as well. As we have seen before, there can be presence of hyperglycemia, weight loss. There can be presence of incidental finding of an adrenal mass, and all this can be triggered in certain situations as well. Like if the patient is receiving anesthesia, some contrast, presence of tricyclic antidepressants or beta blockers. So after we know about the guessing of the clinical symptoms, we have thought about we are suspicious, we have found out that there is a possibility, then how to go about with the biochemical investigations in this particular case. So that brings us to poll number 2. Which biochemical profile is most suggestive of extraadrenal paraganglioma? Whether it is elevated metanephrines or whether it is elevated normal metanephrines predominance, or it is elevated dopamine only, or whether it's a presence of low catecholamines. Over to you, Satish sir. Please launch the poll
Yes,
too.
please launch the poll. Yeah, everyone will get some 10 to 15 seconds to answer the poll. After that, we can declare the results. So which of the following is metanephrines, normetanephrine, dopamine only, or low catecholamines? Which of these is the right
Specifically,
answer? I think we can
extraadrenal paraganglioma.
extraadrenal paraganglioma. So yeah, we can end the poll.
Share the results.
So the house is divided between elevated metanephrines and elevated normetanephrine predominance. But I think it's a very important thing and concept. So there are reasons behind it, and I'll ask Vilesh to expand on this.
Yeah. So basically, it's elevated normetanephrine predominance. We'll go to the next slide to understand it. So going for the first line, so plasma-free metanephrines, basically meta-adrenaline and normetadrenaline is a test of choice. So when we look at the plasma-free metanephrine levels, the sensitivity of the test is 97 to 99%, specificity is 82 to 96%, and that is the first line best for high-risk cases and hereditary cases. You can also do a 24-hour urinary fractionated metanephrines, which are basically first-line alternatives and best for those patients who are having intermittent secretions. And that is sensitivity around 96 to 97 with specificity of around 85 to 95%. We do sometimes, as an adjunct, do 24-hour urinary catecholamines. In large tumors, we can present it. Plasma catecholamine levels are also seen in symptomatic episodes, as well as chromogranin A levels are checked, but they are mainly seen in non-functional PGs and mainly affected by PPI. So the specificity becomes low. The interpretation is very clear. You have to have a more than 4 times the upper limit of normal to say it is highly suspicious. If you're between 1 to 4, we say it is borderline. False positives are present with the presence of drugs which are like PCAs, methyl dopa decongestants, or patient having stress, renal failure. And for such cases where we are doubtful, we do what is called as the clonidine suppression test. After making the patient supine for 15 minutes, you take a borderline sample of blood for metanephrine levels. Then you give clonidine, 300 micrograms, wait for 3 hours, and then recheck the plasma metanephrine levels. If it is not, there's a failure to suppress, it is diagnostic. Precautions before sampling is you should stop all interfering drugs. Patients lying supine at least 20 minutes before sampling. If you're already having an IV line, you can take blood through that. Otherwise, you can have a fresh blood collection. Avoid alcohol, nicotine for 12 hours. It is better to have a preferable overnight fast. And why plasma-free metanephrines? Because it has got a very high negative predictive value, useful in children, best for dopamine secreting tumors, and older than 60 years for an elderly population. And when we look at the diagnostic clue on such cases, when you have a large pheocromocytoma, mainly the metabolites are secreted because the tumor itself metabolizes the main substrate. When you have a small pheo, more chances that your catecholamines are high. When you've got a sporadic pheo, norepinephrine is more than epinephrine. When there is a familial pheo, it's mainly the epinephrine more than norepinephrine. In syndromes, to remember MEN2, MENE stands for epinephrine. So MEN2, the epinephrine release is more. All other syndromes, including VHL, norepinephrine is higher than epinephrine levels. So the drugs which interfere with this particular situations are tricyclic antidepressants, which increase the norepinephrine levels. So you have to discontinue any of these drugs 2 weeks before the particular test is considered. Patient is having levodopa, methyl dopa, any decongestants, they all can trigger the catecholamine release and has to be avoided 44 hours best. ACE inhibitors, caffeine, exercise, stress, and renal failure patients, because of the accumulation of metanephrines, it is to be used cautiously. Definitely, in such cases, metanephrine levels are the best test compared to the urinary test. So, always the levels have to be more than 4 times the upper limit of normal in such cases. So that brings us, after the biochemical evaluation, we understand that we have confirmed that the patient has got a high metanephrine level. We need to know where is the location, how to go about it. So before that, one question on imaging. Which imaging modality has the highest sensitivity for metastatic pheochromocytoma? Whether it's a plain CT, whether it's iodine MIBG scintigraphy, whether it's functional imaging with gadolinium dotatate PET CT, or whether it is MRI. You can launch the poll.
Yeah. So again, we'll give 10 seconds for everyone to answer this poll, after which we can have the results. I think it's time. We can launch the results. Stop the poll and launch. So 64% have got dotatate PET CT. So I think that's probably the right answer. So I'll ask Dr. Vilesh to elaborate on that.
So right, sir. So Jacob sir has already told us that it is not the symptomatology. It's also not the biochemistry. There can be so many puzzling presentations where finally what clinches the diagnosis for us is the imaging investigations. So when we look at imaging investigations, imaging as per protocol is always performed only after biochemical confirmation, never first line. It doesn't mean that you should, if biochemistry is negative, you should not do imaging. It just means that biochemical tests are done first and following which imaging is being done. Now, when you look at imaging, the first imaging of choice is, as said, CT abdomen with contrast. The sensitivity is around 88 to 100%. Specificity is around 70 to 80%. It will tell you the presence of the adrenal mass and the size, and the further images I'll show you in the next slide. MRI abdomen is basically the T2 weighted images show hyperintensity. It has also got a low specificity. MIBG scintigraphy was done commonly in the past actually, but now because of better scan, as sir said, the gadolinium dotatate PET CT, more sensitive, more clarity with 100% specificity, very good for metastatic, hereditary, as well as head and neck PGLs. So it is preferred over MIBG and superior resolution. When we were doing our PG days, we were all doing MIBG scan. Now we have moved to gadolinium dotatate PET CT. And also, more importantly, when you've got a malignant metastasis and on genetic study, when we said about SDHB mutation, then definitely there is a role for FDG PET CT to find out where is the source of the particular lesion. To identify the source of lesion, FDG PET CT will be of great benefit, as high metabolic activity is seen in aggressive tumors. So when you are suspecting a pheochromocytoma, after the biochemistry, we go for imaging. But specifically, this particular rotative imaging and MIBG imaging come under functional imaging. Specifically, also indicated in patients who have got metastatic disease, hereditary syndromes, extraadrenal disease, recurrence of this particular PPGs. CT-MRI is inconclusive. That also we go ahead with the functional imaging. So depending on the tumor type, if it's a head and neck paraganglioma, gadolinium dotatate PET is more useful. If you've got an SDHB metastatic disease, again, gadolinium dotatate PET CT is the imaging of choice. Considering if you're thinking of giving an iodine I331 MIBG therapy, MIBG scan would be helpful. And definitely for any aggressive undifferentiated tumor, you have to consider FDG PET as to better outperforming with comparative to the other imaging modalities. Now let's look at this CT contrast image. You can see that the right adrenal gland has a cystic mass. So this was a case of a cystic pheochromocytoma. On a particular CT imaging, their enhancement will be more than 10 HU. There will be a bit hyper enhancement as well as a delayed washout of contrast. That is one of the characteristics of CT finding. If you look at this image, it's an MR image of pheochromocytoma of a 17-year-old girl. This actual image shows a T1 image in the left upper corner, which is showing a hypointense lesion. But when it comes to the T2 image, it is heterogeneously hyperintense. And this is called as the light bulb bright sign on imaging. So light bulb bright sign on imaging on MRI is indicative of pheochromocytoma. Some
Does it
uncommon
really look like light bulb
presentations.
actually?
So it really looks like that, sir. If you can look at it, it looks like a light inside.
Yeah.
It's because of the hyperintensity within the lesion, because the necrosis again lifts up the like a bulb light
Mhm.
sign. That is the reason for that. And when we look at the other uncommon CT appearances of pheochromocytoma, you've got a cystic PC, which you already discussed on the left side. It's a large cystic mass. Here we have got a PC pheochromocytoma invading both the left renal vein as well as the inferior vena cava. And on the right side, because of a trauma patient having accidental rupture of the pheochromocytoma. So these cases were discussed in different journals, and they have mentioned about the hypertensive crisis which they had to face during the rupture of PCC. So when you come to management, this is the crux of the situation, because once you have got an imaging picture there, we have to now get out of the mass. And when it comes to this, we know that there is a adrenal mass which is releasing catecholamines, and there can be a lot of effects to the when we handle that particular organ. So when we look to that, there are certain precautions to be taken. So first of all, what we all understand is it's not a single team approach. It is a multidisciplinary team. You have endocrinologists to understand the levels for us. Nephrologist looks at the hypertension workup. The surgeon looks at the surgical part. Anesthesia has a lot of importance in handling the tumor during the surgery. Radiologist will give us the interpretation on imaging. Nuclear medicine will help us with the dotated PET scan. Genetics will tell us about 40% germline, which particular type of mutation it is. Oncologists will treat the disease if it is malignant. So it's a multidisciplinary team approach in as far as pheochromocytoma is concerned. And the most important part comes in the pre-operative management. So when you look at the goal, so basically you have to block the catecholamine effect and restore hemodynamic stability before surgery. And the gold standard for this is to have alpha blockade first, and it is mandatory. So basic idea is to overrun the excess catecholamine activity by not giving beta blocker first. So phenoxybenzamine starting at 10 mg BD, titrating to 1 mg per kg per day, or doxazocin. Most of the endocrinologists nowadays use prazosin. Duration is minimum 10 to 14 days pre-op. So it is there are certain targets to achieve. You have to minimize the blood pressure so as much as less than 130 per 80 millimeters of mercury. And there is a just before the presence of postural drop. You can that's the endpoint of alpha blockade. That is the point where we add beta blockade. That is adding propranolol, atenolol. If tachycardia is present, never start beta blocker alone. It is always the alpha blockade followed by beta blockade. The risk of hypertensive crisis is the reason why we have to block the alpha stimulation before. And here we target the heart rate between 60 to 80 beats per minute. And the most important thing, what happens, it basically causes so much of vasoconstriction and volume contraction. So basically, as soon as that effect goes off, there will be a severe vasodilatation and will be low on the fluids and the volume inside the vessels. So the volume expansion and diet plays a significant role in the management of Pheocromocytoma. So we need a high salt diet and liberal fluid intake to counteract this catecholamine induced volume contraction so that we can reduce the post-op hypotensive risk. So giving salt and fluid intake as well as starting with alpha blockade and secondarily adding beta blockade is one of the preoperative most important medical management. Proceeding to intraoperative management, this is just to point out that we remember few things. That's it. We are not going to give the anesthesia to the patient, but while discussion, definitely we can remember this that the preferred induction agent is propofol or etomidate. We are trying to avoid fentanyl, ketamine, morphine, desflurane, and halothane in these patients. Alpha beta blockage is already medicines will be given early morning of the day of surgery, which has been going on for the last 15 days. And more importantly, when you do surgery, if you're either doing laparoscopically, then most important the tumor will be rated as less than 6 centimeter. We can consider laparoscopic evaluation. Otherwise, we should consider open. So bringing this to the in the management itself, coming to pole 4, we are in the intraoperative phase. We are trying to manage the hypertension. So which IV hypertensive agent is particularly useful intraoperatively during pheochromocytoma surgery? Is it labetalol? Is it nitroprusside, hydralazine, or NTG? All four are used, but which according to you is the most effective in such patients?
I think poll has been launched, so please everyone give out your options. And then in 10 seconds, we'll close the poll.
The poll is getting launched before, like it's very fast, very good.
So we'll finish off the poll. Yeah. Okay. So I think 35% have gone for it. But then you see the values are distributed all around. People are not very sure about what to use. So I think you need to educate them.
No, sir. Actually, all the things are fairly correct, but the most common fast act and the fastest reversal is with nitroprusside. So they prefer nitroprusside in the OT actually. So I'll just get to that. So hypertensive critically crisis is basically a medical emergency. Mortality without treatment is almost 30%. So ICU HDU admission, arterial line continuous monitoring obviously being done. This is what sir was saying, pintolamine 2 to 5 milligram bolus alpha blocker was a crisis of choice. But most importantly in the OT, it's IV sodium nitroprusside as an infusion, which is preferred, followed by IV labetalol, which has to be used with cautiousness, basically because of the associated beta activity as well. Patients who have got any sort of arrhythmias, they prefer to give esmolol and avoiding verapamil. This is just a point of concern mentioned during intraoperative arrhythmias treatment. They had mentioned this point. Beta blockers alone, unopposed, we have already discussed about it. Glucocorticoids stimulate the catecholamine release, so that's why it should be avoided. And drugs like metoclopramide, glucagon stimulating factor, we are generally not going to give during the surgery. Volume, we are going to aggressively give IV crystalloid resuscitation for hypertension post-surgery. So definitely these will be the drugs which will be considered intraoperatively. Now coming to the surgical management. So once you have got to the point, pre-anesthesia treatment has been given, patient is well managed till this point. Now it is the time to resect and give a curative treatment for PPLG. So here the preferred approach, as I mentioned before, the fuse size is less than 6 centimeter, then we should consider laparoscopic adenectomy if possible. It has a very short hospital stay and less morbidity. That is a gold standard for unilateral adrenal FEO. Open adenotomy is done for large tumors more than 6 centimeters, tumors which have invasive on the scans, and if you have got any other abdominal surgery done before. Cortical sparing adenolectomy is done for bilateral FEO, mainly in the hereditary syndromes, to avoid lifelong steroid dependence. Mostly, they leave back only one side. Paraganglioma resection approach determined by location. So basically, whether it is retroperitoneal, thoracic, scopic, or even open approach. Now, we have already dealt with the hazards, that it is a catecholamine surge which we have to look into, and the post-resection hypertension which can be managed with IV fluids and the IV alpha agonist. So once we have done with this management and we have come to a conclusion that the single pheochromocytoma which has been removed, whether it is hereditary, whether it is solo adrenal pheochromocytoma, but now at the same time on the imaging, suppose you find a malignant PPGL, then how will you like to go about it? I'm not going to touch in the deep details, but at least certain points which will help us in moving in the management. Before that, I would like to post a poll number 5. In malignant pheochromocytoma, the definitive criteria for malignancy is whether it is the tumor size more than 5 centimeters, or is it the high catecholamine levels, or is it the presence of metastasis, or is it the presence of bilateral disease. You can launch the poll. So what
Again,
defines
I request,
malignancy in
yeah,
pheochromocytoma? Over to you, sir.
yeah, I think everybody is doing faster. Poll. So I think we can end the poll
Share
now
that.
and
Yeah,
share the results. Yeah, presence of, but I think that is for metastasis,
that,
definitely it must be malignant, no? It
correct.
can't
So
be
in the first
benign.
slide only, I had already shown this.
Hmm.
So, can I proceed?
Yeah, yeah, proceed, proceed. Yeah.
So when you're talking about malignancy, presence of metastasis, that is lymph node, bone, liver, and lung, not the histological criteria. It is basically the presence of metastasis which decides about the malignancy or potential of the tumor. It is mainly seen in the SDHB germline mutation. That is the strongest predictor. I'm again and again repeating this word SDHB so that
Hmm.
it sticks to our minds in the future. Whenever you get a genetic report showing this, you know that you have to go for the gadolinium dotatate scan and find out whether there is metastasis. Extraadrenal location, definitely you should think about malignancy. Large tumor size more than 5 centimeters, you should look for malignancy. And there are certain indexes given like KI67 and scoring systems, which will not go in the details. But the treatment options are very interesting in this. We all know that metastatic lesion has to be removed. So surgical debulking, wherever possible, we should try. Whenever we are talking about the iodine MIBG therapy, it can be used that wherever they have used an MIBG scan to identify that Azadra is the drug which has been recently approved by FDA, can be used. But what we hear most as a treatment from the oncology side is a lucium dotrate, PRPAT, that is for the somatostatin receptor positive tumors. So every time you will hear the word lucium, chemotherapy is for those diseases which we cannot surgically evacuate, and that is cyclophosphamide, vincristine, and dacarbazine. Targeted therapies, this word I highlighted is cabozantinib because this is the current very hot in the journals because of the recent trials which are helping out to patients who are having metastasis. So cabozantinib is one of the drugs related to FEO. And the as always, we mentioned about the multidisciplinary approach. So 5 year survival is 50% for malignant PPGLs, but better outcomes are seen with early detection and MIBG therapy. So this talks about the different aspects about the malignant pheochromocytoma. So after we done the whole hard work, we have finished up with the debulking of the surgery as well as treating the pheo. But most important, the biggest step is actually the follow-up. So what are the time points where we need to assess these patients? So 24 to 48 hours post-op, definitely BP monitoring, glucose, cortisol, and definitely we have to supplement steroid wherever you have removed bilateral adrenectomy. But at 2 and 4 weeks post-op, as well as 3 months, we have to repeat the metanephrine levels. We have to ensure complete resection by looking at the levels. And for lifelong, annually, you have to definitely see for plasma metanephrines every year and even imaging in certain situations if any abnormality is suspected. The risk of recurrence and meta is high in all PPGs, and that's why it's very important to look for it in the follow-up as well. Certain patients where there is hereditary, we have to look for the full syndromic surveillance, specifically to MEN2 and VHL, and the patients who are having SDHB mutations. Genetic counseling is offered to almost all patients to rule out if any germline test is required for that. Biochemical recurrence is 6.5 to 16.5% in benign PO and almost 50% in malignant PO. So that's why recurrence rate is definitely high. Patients with hereditary PPGL require lifelong multidisciplinary surveillance. That is, and stress and steroid response will be definitely supplementing with steroids. So this follow-up is very important. That's what this slide highlights. So when we come to the renal impact, it is just a few things, but that's anecdotal case reports and the things have been compiled. Before that, we'll go for a small poll. last poll of the
Yeah.
Pheocromocytoma in ESRD patients. Which statement is false? Whether it is the plasma nephrin is the test of choice in these patients. Reference ranges in HD are defined as 2 to 3 times the upper limit of normal. Alpha blockers should be used cautiously due to enhanced effect. Surgical risk is higher in patients with ESRD. Which statement is false? You can launch the poll.
Yeah. I think not an easy question. Everything looks correct, actually.
But actually,
But
I've
I
given
think
the
there
answer
must
in
be
the
one
second
wrong
slide.
answer. Yeah, there must be one wrong answer. I
Yes.
think, yes, but I don't think everybody has guessed the wrong answer correctly. So I think you should
Close the
explain
poll.
the question
Yeah, I'll
carefully.
explain soon. Stop sharing and can you give us poll results? Yeah, thank you.
Yeah.
So when we look at PPGL in ESRD and dialysis patients, the prevalence remain rare even in ESRD population, but it's a treatable cause of refractory hypertension. So plasma-free metanephrines are the preferred test because it's confounded by dialysis and the urinary tests are not correct. Because of that, the plasma-free metanephrines are the preferred ones. But the only thing is when you look for patients who are in dialysis as well as CKD, the limit should be always more than 4 times the upper limit of normal as threshold. It's not like 2 to 3 of upper limit of normal. It should be always 4 times more because minimum that much will be seen because of the accumulation of metanephrines. And management alpha blockade should be used with caution because of the enhanced hypertensive effect, as well as whenever you do a surgery in these patients, they're definitely at high risk and there is higher perioperative morbidity. But when you look at the effects of catecholamines, there are episodes of severe hypertension which causes glomerular injury, causing hypertensive nephrosclerosis in long run. Patients with vasoconstriction definitely reduces the renal perfusion, so definitely reduces the renal blood flow. There have been case reports of catecholamine-induced muscle ischemia presenting like rhabdomyolysis-associated AKI. Also, there have been case presents like patient catecholamine-induced microangiopathies, almost simulating like an hemolytic uremic syndrome. Because of podocyte injury, there can be subclinical proteinuria as well. The diagnostic challenge, as mentioned before, it has metanephrines are renally cleared, so they accumulate. So therefore, we need more than 4 times the upper limit of normal. 24-hour urine collection is unreliable because of incomplete collections. Strategy is to use plasma-free metanephrine levels. Clonidine suppression test does not work in CKD, and functional imaging gadolinium dotatate PET is will help us to clarify the biochemistry, and it's whenever everything else is equivocal. So there also our functional imaging would give us the diagnosis. So when you look at finally the algorithm for suspected PPGL, we have to have a clinical suspicion. As Jacob sir said, it may not be evident. Patient may not have incidence symptoms. It will be always something like an incidentoma. Deciding on that, we may go for a plasma-free metanephrine levels. There are cases when they are also borderline. It is when there is a presence of incidentoma, we have to think about an imaging at that point of time. And that imaging either CT, MRI, abdomen, or mostly the CT contrast, which is the best thing to do. And after doing the CT contrast, to get a functional imaging to clarify the by using a gallium dotatate or an MIBG, which was being done previously. So that brings us to a case study. So this case study is of a 21-year-old female admitted for evaluation of the following symptoms. They hail from Bihar. So it's episodic flushing, red to purple patches on the skin, over face, chest, and limbs, which lasted for few minutes to an hour. These patches disappear by themselves. So by the time we are called in or we are going to see the patient, if you are at the right time present there, you see. If you go later, it is not there. During these episodes, her BP was found to be borderline, sometimes 150, sometimes 170. Definite tachycardia and sweating. Now, every time her relatives will say that this happens and she feels tensed, and that is why they labeled her as panic attacks. And they were not majorly looking into it in very seriously, and they were taking her to all possible clinics around their home and around, and was receiving some symptomatic treatment for that, including even an antidepressant. Now, looking into deep history, there was no history of any collagen vascular disease, no history of any alleged intake of drugs, stimulants, alternative medications, no history of any muscle weakness or focal neurological deficits, no history of any bleeding disorders or congenital anomalies, no family history of similar episodes, no history of any systemic illness. So nothing was there actually. She's just a young girl who's telling there's some patches come and I feel very worried. My heart rate is high and that time the BP is high. So when the in view of this episodic flushing and hypertension, sweating, panic attacks, so they were thinking of some neuroendocrine tumor. Pheocromocytoma was very high on cards in the endocrinologist's mind. Some paraneoplastic also they were thinking because of weight loss. Collagen vascular can be missed, just they have done only ANA, we have to do ANA profile and other things, though there is nothing in the history to suggest that, or some other cause of secondary hypertension and she is presenting vaguely, or some skin disease. Now, clinically, the pulse was 88 per minute, BP was 130/70 when I see this patient. No skin patches. I'm just a first year medicine student at this point, and no skin patches mentioned in the history. Other than what has been mentioned, I could see on her. No systemic findings. Investigation, just a low hemoglobin. Renal function test, liver function test, ANA, ESR, CRP, electrolytes, everything normal. Ultrasound abdomen done normal. 2D echo was also within the normal limits. 24-hour urinary VMA. So as Dr. Arun said, there was a time when only this test was done, 24-hour urinary VMA. Nowadays, most of the endocrinologists don't even do this test. They only go for serum metanephrine level. So that time, 24-hour urinary VMA was the top class test. It was done, but it showed borderline. Also, what was done along with this, which was another common test done all over those times, was serum chromogranin levels. So that chromogranin A level was very high. So based on this, since the patient had some clinical hints, plus high chromogranin A levels and a borderline urinary VMA, suspected pheocromocytoma or maybe a paraganglioma, she underwent a CT abdomen contrast pelvis. Now, CT abdomen pelvis turned out to be normal. In view of the symptoms, she was subjected to a PET-CT to look for any paraganglioma or extraadrenal site because the endocrinologist is very sure that she is having this. But PET-CT showed up uptake in the appendix. Now, because it was in the appendix and nothing else to prove, symptoms are going on for a few months. Family agreed and the surgeon agreed and finally underwent a appendicectomy. Everything was planned as such. There's going to be a crisis, so they were given whatever alpha, beta blocker, but there's no blood pressure to control at that time. It is only episodic. But the patient was given well hydrated. Everything, all care was taken, and appendicectomy was done. One blood report was yet to come. One urine report was yet to come, and a histology was awaited. And this is what it turns out to be. So the blood report serum serotonin levels and the 24-hour urinary serotonin FHIA levels are high. And the patient turned out to be a carcinoid appendix. So how does this carcinoid syndrome differ from pheochromocytoma? Both are neuroendocrine tumors. One side, it is usually present in the GI lung. Catecholamine producing is for the pheo. Main hormones are serotonin, histamine, and bradykinin. Here it is mainly catecholamines, which we have already seen. The classical symptom here is this episodic flushing. Sometimes they can have diarrhea. Many of them complain of diarrhea in carcinoid syndrome. The BP pattern was almost low, sometimes variable. So here, because the patient was repeatedly getting the symptoms, she was anxious about it. That's why she was getting an anxiety attack and hyper tachycardia and blood pressure at those times only. But all other times the BP was okay. But we know in pheochromocytoma it can be really high. Diagnostic test is 24-hour urinary serotonin levels. Here it is the plasma-free metanephrine levels. So that was a googly for us, and eventually after this, her symptoms definitely became better, and she was fine. So with all these things,
Yeah.
what we said, if I can just bring down to my key take-home messages for today is that whenever you screen for PPG in all patients with resistant hypertension or unexplained hypertension, you can consider it as a treatable cause for sure, but it is only in cases where you're suspecting PPGL. Second, plasma-free metanephrines are the preferred first-line biochemical test, superior sensitivity and less affected by CKD and any other urine test. Interpret metanephrine results cautiously in CKD. We said that it should be at least 4 times the upper limit of the threshold. Always alpha blocker first. Starting beta blocker alone can precipitate your hypertensive crisis. Because it's having a germline mutation in 40% of the patient, genetic testing is very, very important. And this has to continue as a surveillance, and family screening also should be done. And as we all saw that it is a multidisciplinary approach. It is nephrology, endocrinology, surgery, nuclear medicine, everybody coming together and to obtain an optimal outcome. These are my
Yeah.
references, and thank you very much for the patient listening, sir.